I'm going to move on now, and in fact it's myself who's going to do the next lecture. So if I'm going to bring up my slides, so what we're going to use here is in liver imaging. And I'm going to first talk to you about how safe it is to use contrast enhanced ultrasound, because we're all brought up with, as radiologists, that the diagnostic CT and MR has always been the way we're looking to use contrast, and ultrasound has always been without contrast enhancement. But this has all changed recently, and you'll see that the safety is beyond question. This is a retrospective analysis of 23,000 patients in the Italian society, and they found that the rate of adverse effects was only 0.0086%. Now, the most important is, of course, to have post-surveillance assessment. And this is from the BRCA's own data, a couple of years old, looking at the post-surveillance data. And you can see in their data reported to them show that there was only 14 deaths overall in 2.5 million administrations, most of this in cardiology, where the patient is quite ill anyway. So there's very, very low adverse effects and death rates. EFSUMB has produced a number of guidelines over the years, and this is based on the number of publications, etc., that have come out over the many, many years. So we're looking at over 4,500 papers now. Initially, the guidelines were produced in 2004 for liver, then updated in 2008, and then subsequently in non-hepatic applications in 2011, repeating the liver guidelines. And recently also the non-liver guidelines were updated, and importantly, a position statement on the use in pediatric patients. Also, for those of you in North America, it's important to realize that the FDA has also now approved the use of contrast, Lumason or Sonoview in the United States, for assessment of focal liver lesions, both in pediatrics and in adults. We will shortly be issuing, and this is about to be released now, the most up-to-date liver contrast guidelines, the update in 2020, and this more or less brings it all up to date over the last 25 years of clinical practice. In the United Kingdom, we have a group called the NICE group, which is the National Institute for Clinical Excellence, and they've looked at the use of contrast enhanced ultrasound for liver usage, and they've actually recommended, and this is important in the United Kingdom because once a recommendation is made by NICE, we're more or less obliged to follow these recommendations. And they've recommended that you use contrast enhanced ultrasound in specific areas with the liver, looking at any incidentally detected focal liver lesion that comes through your practice. Also to look at investigating a patient for potential liver metastases, and also to look at those focal lesions in liver disease. This is all what we do anyway in clinical practice, but it's backed up by an Institute for Clinical Excellence in the United Kingdom. Now, what about the incidental focal liver lesion? Now, we're talking about a lesion that when you're doing your ultrasound examination, you find a lesion in a patient that has no other risk factors, but has come to you because of vague symptoms like upper abdominal pain, or they've had a blood test with their primary care physician, which shows some abnormal liver function test, or very often it's for something completely different that they've come and you've been looking at the liver. And it's important to appreciate that in these patients who are not coming from an oncological background, that nearly all of these lesions will be benign. And this is where, as a radiologist or a physician, you are able to say to the patient, yes, this is a benign lesion, don't worry, with immediate effect. Otherwise, you have a patient who's going to go home and wait for further investigations to confirm that it's a benign lesion. And very often these benign lesions are hemangiomas. But beware these days, of course, the hemangioma is not as typical presentation, particularly in the fatty liver, as it used to be. Now, looking at the use of contrast in liver disease, DEGEM, which is the German Society for Ultrasound, has looked at the use of contrast-enhanced ultrasounds in this situation, and they produced 2 landmark papers on this. One was to say that it was very accurate and reliable in compared to MRI for lesions differentiating benign and malignant lesions. So this is the most important thing for you as a practitioner at point of care ultrasound. But also Degum has indicated that there is a cost saving for the German healthcare by introducing contrast-enhanced ultrasound in the pathway, so you stop the downstream investigations. So looking at focal liver lesions, EFSUMB has clearly indicated that this is where, in the guidelines, you should be using contrast-enhanced ultrasound, because in fact it equals contrast-enhanced CT looking at these lesions, but it has the advantage that it's advantage in detecting and both characterization of the lesion, but you're there, the examiner, throughout the examination, and you appreciate all of the stages of a contrast-enhanced ultrasound. And more importantly, the ultrasound contrast agent is truly intravascular, it's not leaking, there's no equilibrium phase. So if there is washout in that lesion, you will see washout. Richard Barr has produced a review paper looking at the evidence of how you would look at these focal liver lesions with ultrasound, CT, MR, and contrast-enhanced ultrasound, and he's looked at the literature. And importantly, very often you're looking at comparing unenhanced ultrasound with contrast-enhanced CT. This is not a level playing field. So if you compare unenhanced ultrasound to contrast-enhanced ultrasound, the sensitivity and the specificity increases dramatically when you add contrast. So really, your unenhanced ultrasound examination is not a good examination for a focal liver lesion. When you compare contrast-enhanced ultrasound with CT, and this is looking at the Degum study in particular, but there are other studies out there looking at that, and your sensitivity and specificity is slightly higher than CT. This, of course, the proviso is that sometimes you don't even see the lesion on ultrasound because the patient's body habitus prevents you from doing this. But this is an important fact is that if you see the lesion, you'll see it best with ultrasound and you'll be able to characterize it the best of all. And it's very good for the benign lesions, for the hemangioma, FNH, but it's also good for HCC and metastases, and it's particularly good for the washout, earlier washout in metastatic disease. And Richard Barr has recommended that the literature shows that contrast-enhanced ultrasound is appropriate for focal liver lesions, and in the USA where he works, it should be included in the characterization of focal liver lesions. So in your clinical practice, you should be using contrast-enhanced ultrasound wherever you can. Just let me show you these two images. Here on the left is an unenhanced CT. No radiologist is going to report on that for focal liver lesions, but as soon as you've added contrast, there are two focal liver lesions here. Look at the ultrasound. The ultrasound clearly sees a focal lesion here, but it's benign because after adding contrast, it disappears. So there are different concepts of how you use contrast-enhanced ultrasound and comparing it to CT. Let's now look at the benign focal liver lesions that we have. Now, most common is the cavernous hemangioma, and the hallmark of a cavernous hemangioma is this peripheral globular enhancement, just like you see on a CT examination, and over time that fills in. Any focal liver lesion that remains bright or retains contrast after the examination is a benign lesion. And you can see it in the real time, just as I was talking, we've made that diagnosis in a matter of 5, 10, 15 seconds, that is a hemangioma. So clearly demonstrated of infilling from the periphery and retaining that contrast-enhanced ultrasound, but also that patient's breathing, the liver is moving, but you're not losing sight of the examination of that particular focal lesion, and you're not dependent on producing an image at a time that the technician thinks it's suitable for you to be viewing. You see it in real time. Look at this now, a focal nodular hyperplasia. It is different. It is different from a cavernous hemangioma because it's a much rarer disease. But even so, it may be subtle and you can't pick it up. But watch very carefully because as it comes in the arterial phase and very transiently, you'll see that spoke wheel appearance there that comes and goes as quickly as within 3, 4, 5 seconds. There's no other imaging modality that will pick up this stellate spoke wheel appearance as can ultrasound contrast. So you're at an advantage for in this diagnostic phase to clearly make the correct diagnosis. Hepatic adenomas behave slightly differently. They can be quite subtle, that you may not see it so clearly, and it's also rarer than a focal nodular hyperplasia. And look at this adenoma. It filled very differently from the FNH. These two should not wash out, but it's becoming more clear that the pathophysiology, the pathology of these lesions are different, and there may be some washout, the hallmark of malignancy, which may confuse the situation. I show you a case. I illustrate this case. This is in fact a 6-year-old girl who had a malignancy of the ovary and on follow-up had a focal lesion in the liver. This enhances with contrast-enhanced ultrasound and then washes out. The MR confirms that this is a malignant type lesion and the PET CT is positive. Now, there was still some doubt about what we were managing here. So the patient had a biopsy, and the biopsy showed you that it was a well-demarcated lesion, which was a hepatocellular adenoma. And there are 8 reported PET CT positive hepatocellular adenomas in the literature. But what's important here is that not so much that the contrast showed washout, but all imaging modalities also showed the same thing as we see with the contrast-enhanced ultrasound. And this is the most recent paper demonstrating the different types and who has the chance of malignancy. So it's not quite so clear in adenomas. Same thing with regenerative nodules. The regenerative nodules should not hyper-enhance and should not wash out to show you benign disease. But this is a difficult thing because you're looking at a cirrhotic liver and you're looking for a spread of disease over the area from the regenerative nodule to the dysplastic nodule to the well-differentiated HCC to the poorly differentiated HCC. So this becomes a difficult diagnosis to make. But again, the hallmark for a presence of the HCC is the washout, but it may be much later in the course of the examination, maybe 5 minutes after the injection. Another interesting area, and we see much more of this, particularly in the pediatric patients now, is focal fatty sparing and infiltration. And of course, it's nice to be able to do an ultrasound contrast examination in a patient with this sort of focal lesion to alleviate the anxiety not only of the parents, but the referring physician. And it should behave exactly like the rest of the liver. However, as we've seen more and more of these cases, and in keeping with our clinical perception, we felt that some of these areas of focal fatty sparing actually take a little bit longer to enhance. And we've got a publication coming through shortly to show you that there is some slower enhancement in focal fatty sparing, but not in focal fatty infiltration. And we're not sure why. Malignant focal lesions, again, the hallmark is washout. And in your clinical practice, the most likely things you're going to pick up a metastatic disease, although you may see some HCCs coming through. And this is where you've got a focal lesion in a patient who's got underlying breast cancer. And in a surveillance ultrasound, you're picking up somewhere that's hyper-enhancing and then washing out. And you can see in the video clip here, you'll see the lesion just here, slightly hyper-enhancing earlier than the rest of the liver, but almost immediately showing pockets of areas of washout as you're going down. And this is a hallmark of a metastatic disease, that it washes out quite early. So if you look at this pathway here, what you're looking for, the most common areas of in focal liver lesions is that look at the late phase. If the late phase, the phase is normal and equal to liver, then it's going to be benign lesion. Hemangioma, focal nodular hyperplasia, hepatocellular adenoma is the most likely. And it's the pattern of the arterial enhancement on your cine loop that gives it away. So peripheral nodular enhancements, the hemangioma, that branching radial spoke wheel pattern is a focal nodular hyperplasia. And go back at your cine loop of your video. Play it slowly. Look for that little spark of arterialization. And then there's a diffuse enhancement with the adenoma, but beware the adenoma that washes out. But if it's less than normal liver, if it's a black hole, then it's going to be a metastases, a vascular or avascular metastases, but the metastases wash out much quicker than your hepatocellular carcinoma, which depends on the degree of differentiation. And many people are looking at grading and categorizing hepatocellular carcinomas. And very recently, the American American Radiological Society have issued the CEUS LIRADS guidelines, and I encourage you to look at those as well. But there are other areas that we use it. In the last 5 minutes, I'm going to show you where we use it in liver transplantation, looking at arterial or vascular issues with liver transplantation. As you are aware, the hepatic artery is crucial to the understanding and the well-being of that transplant, because if you lose that artery in the following post-transplantation, you're likely to have much problems with the graft. But look how in this patient with drains in position, you've picked up the artery going through very quickly, that it's patent, but this is on the ITU setting. And similarly with this second patient, you pick the artery early on. But what happens now is you get less and less clear view of that artery because of the portal venous flow coming through. So it's very useful as a bedside test to confirm, if you can't see it with color Doppler, that you can pick it up with contrast enhanced ultrasound. And this also show you another example here on the ITU position where you're not seeing the hepatic artery so well, but what can you add contrast? Well, look at this same patient, and we've added contrast, and you can see how clearly you can see the aorta, the celiac axis, the splenic artery, but there is no hepatic artery there at all. So a very useful bedside point of care test to say, yes, you've lost the hepatic artery, and we're very confident that this is the case. So let's do something about it. We also use it sometimes in picking up pseudoaneurysms. Very rarely do you see a pseudoaneurysm. About 1% of patients have a pseudoaneurysm. It may be extrahepatic or intrahepatic. And if it's intrahepatic, it's usually due to an interventional procedure like a biopsy. And if you have an intrahepatic pseudoaneurysm, the prognosis is much better. If it's extrahepatic, it's due to sepsis, usually fungal, and there's a breakdown at the anastomosis site. And there is a mortality of 67%. Here you see a pseudoaneurysm very clearly with the contrast enhanced ultrasound confirmed on the CT-A and angiography. But what you can use it for is to use it in the follow-up of these pseudoaneurysms to make sure it's actually cleared. So here is someone very subtly, there's coil embolization has occurred, but you can see with the contrast enhanced ultrasound, it's still filling up that pseudoaneurysm. So it's not quite treated fully. So in conclusion, I'm going to say to you, it's very important to add contrast enhanced ultrasound to your diagnostic capabilities in focal liver lesions, because you can instantly give that patient an answer. The patient knows you've found something wrong because he's watching your face or she's watching your face, and you can't hide these things. But remember, from the community, from the primary care physician, that focal liver lesion is almost certainly going to be benign. And how wonderful it is to be able to tell to the patient, I have great confidence that this is benign. We'll have a look at it. You may not need any more investigations. Look at it if you've got inpatients with issues with vascularity and liver transplantation, how you can give an intensive care unit point of care answer to this. And also consider extending this practice to your pediatric patients, because remember, it is licensed Lumason in the United States, and more people use it here in Europe for assessing the focal liver lesions in the children. Thank you very much. Okay, how to differentiate recanalized thrombus from tumor thrombus, since both will enhance? That's a question for Dirk, I think. Dirk, are you still on the line, Professor Cleavett?
Yeah, I'm still on the line. So if you have got a tumor thrombus, you will see a very, very strong enhancement. It's similar like when the contrast bubbles arrived in the artery, immediately these thrombus show a very strong uptake, like liver mets, for example. A normal thrombus doesn't show any contrast uptake. If there's a revascularization of the thrombus, you see tiny bubbles entering the thrombus, but this is much a delay in comparison to a tumor thrombus.
Okay, and I think that's certainly my experience as well, that tumor thrombus enhance very greatly. The other question for you, Dirk, is have you used contrast enhanced ultrasound in giant cell arthritis?
I have done one case. But honestly, we don't have this kind of patient population here, so I don't have major experience with this. But you also see enhancement of the wall. It's like an inflammatory disease. You see a thickness of the wall, and also this wall shown uptake. So if you measure the contrast uptake of the wall, you can see whether the progress or a regress of disease.
Yeah. And I think I've just recently seen a paper, not so much on giant cell arthritis, but in Takayasu's arthritis. And I think it's been published in Ultrasound in the medicine, showing that following treatment, the contrast enhanced features regress. So yes, I think it probably is useful. I've got a question now for me. Is it possible to use contrast agent Optison in liver imaging? And does the use of Ultrasound have any contraindications and adverse reactions? So I think all three of our speakers will probably have very limited use in Ultrasound. I did use it for a short period of time, but I think it is used in other areas of the world. And I don't know of the contraindication adverse reactions. Professor Cleveland or Professor Fisher, have you any comment on that?
So I had a couple of patients where I used Optison. That was starting in the year 2000. I mean, the problem is with this kind of contrast agent, it's a little bit more stable in comparison to sonography, so the MI should be a little higher. But also the shell is a human albumin shell. And this is probably also the risk why you have more side effects in comparison to other contrast agents.
Yeah. Certainly, that's what the literature has suggested, that the Optison has a higher level of adverse reactions, but still not very high. And one last question before I move on is, can you differentiate a dysplastic nodule from an HCC? Now, this is a question that's difficult. The answer is, if it's a well-differentiated HCC, you have to wait for quite a long time before you see any washout in that lesion. So we're talking about 4 or 5 minutes into the contrast examination, whereas in a metastasis, it'll wash out a little bit more. Remember, there's a finite time that your contrast agent will show up. It's 5, 6, 7 minutes at most, and then it starts to be burnt off, disappearing. So if at that time you've got no washout in the lesion, you're going to have to say that it's probably not a malignant lesion, but you're going to follow it up clinically, I'm absolutely sure.